Hey everybody, my name is Dr. Karan Saravana and I'm joined by Doctors David Frank and Jonathan Meadows. And we are recording this asynchronous lecture talking about medical toxicology with an international perspective. So, a quick disclaimer slide. So, these lectures are intended for educational purposes only and should not be considered as professional advice. It does not reflect the position by ASEP, the University of Arizona, or any other entity. Additionally, the information provided is for general informational purposes and it does not constitute a recommendation or endorsement of any particular service, product, or opinion. And the lecturers are not responsible for any decisions or actions taken by participants based on the information presented in this lecture. And please always consult with the appropriate professional for any specific needs or concerns. So the objectives for this lecture first is to appreciate the vast diversity of toxicological conditions in limited resource settings, so largely in international settings. Understanding the global burden of disease of poisonings is another objective. So is identifying public health strategies to address toxicological conditions. And finally, to discuss finding opportunities and planning for emergency medicine and global health electives and, quote, thinking globally and acting locally. So, a quick introduction to this lecture. So, this is a quote from the Goldfrank's toxicological book. Basically, it says that poisoning is a worldwide problem, but the major effects are felt in the developing world. And this is largely true. So, in a lot of cases that you'll see today, rural communities are largely and disproportionately affected by toxicological issues, cases, and there's often a lack of knowledge and resources to address a lot of these issues. Medical toxicology largely has a reduced presence due to reduced infrastructure, resources, education, etc.
Hi everybody, my name is David Frank and I am PGY2 Emergency Medicine here at the U of A. I'm going to be talking to you guys about the next couple slides, including poisoning and the global burden of disease. And in 2004, there was an estimated 4.9 million deaths that occurred from both acute and chronic exposure, as well as $86 million worth of disability-adjusted life years, and that was presumed to be more than cancer, STIs, or diabetes combined, with 50% of them being children less than 15 years of age. And that's likely due to the fact that some of these kids are doing tasks that adults don't necessarily want to do, and potentially different kinds of jobs, and might have a higher exposure to some of these things that can cause poisoning. 75% or more than all the poisoning-related deaths are in the developing world, with 95% of the pediatric mortality being from these LMICs, which stands for low middle income countries. And the poisonings have reduced clinical recognition in some of these areas, which kind of results in this delay and therefore higher mortality rate that we see. Moving on, we have common xenobiotics and patterns of poisoning to discuss. Xenobiotics, by definition, is basically a synthetic compound that can be introduced into an organism or even an ecosystem, resulting in some kind of problem, essentially. And so we see that xenobiotics differ among different countries and communities. As an example of this, you can see that in New York City, 70% of patients with this exposure that can cause harm is a result of pharmaceuticals, whereas in Sri Lanka, it's 90% of them are from botanicals, which is more of like a natural-based substance rather than a pharmaceutical company creating this in mass production. So things that we might see would be pesticides and venomations, herbal and traditional medicines, and pharmaceuticals, as mentioned before, household products, plants, and then different occupational and environmental sources as well. And moving on to pesticides, so this is actually responsible for millions of hospital admissions and over 150,000 deaths per year, which most of these take place in Asia, such as China and India, and the most common reason that we actually see in these areas is intentional self-harm. It's cheap, it's a little bit more easily accessible, and therefore it makes it more likely that it is more reasonable for them to get a hold of, and the WHO on pesticide poisoning states that the single most important means of suicide is from pesticides, and that's because 30% of them, so almost a third of all suicides worldwide, are due to pesticides. And most of them are due to specifically organic phosphorus pesticides, in which case we can see from different sources that case fatality rate of organic phosphate or phosphorus pesticides in Sri Lanka is 21%, with such a high amount of people needing ICU status in order to help with management. All right, so now moving on to envenomation snake bites. Few countries actually kind of report this. It kind of becomes a little bit more difficult, and I think some of it has to do with the fact that these areas that you see a little bit more commonly don't really think to report them as much, and it's estimated that anywhere between 421,000 and 1.8 million envenomations and a significant amount of deaths occur each year from snake bites themselves. Most of these are going to occur in South Asia, Southeast Asia, and sub-Saharan Africa. Less than 100 snakebite deaths occur per year within Europe, the US, and Canada, and Australia combined. And the likely disparity due to this increased incidence and decreased ability to care for them is probably due to the access of an anti-venom, trained personnel, etc. I actually had someone that I went to a lecture for, and he was discussing that he actually went to a place in sub-Saharan Africa where they had some vials of anti-venom that they had to distribute. And so unlike here where we're currently located, we can just give 10 vials right off the bat to people. They actually really had to think about how many vials that they were giving out to each person, and it wasn't just okay, we're giving just 10 right away. It was a give a couple and then see, because the resources were so limited. And so that's why we see these increased deaths per year from these different areas. And continuing on with the envenomation snake bites, there is an increasing occupational exposure in rural tropical countries, actually, and is actually considered a neglected tropical disease as determined by the WHO. Such as other things that we might consider would be like loa loa or leishmaniasis as other examples. And we see that changes in global climate and expansion of these human settlements increase the range of venomous snakes, including into urban areas themselves, and which is why we have this increase in envenomation and snake bites. And then substantial burden on the healthcare system is very obvious into taking into account the amount of exposures that happen. Interestingly, there was a household survey in Bangladesh that was done that showed about 86% of people went to snake charmers for an initial management of the snake, and only 10% later sought allopathic care. So that kind of tells you that maybe some of these people who were coming in trying to handle the snake wasn't necessarily trained properly in order to kind of keep their distance and whatever else, resulting in some potential for increased risk of snake bite at that time. And the Elapidae, which is your cobras and mambas, and then the Viperidae families, such as the pit vipers, are responsible for the majority of these deaths worldwide. All right, and of course, on the talk of envenomation, we also have scorpion stings. Most common morbidity in North Africa, Mexico, India, and Brazil, with over 1.2 million stings per year, and likely even more than this, but about 3,250 deaths per year, with two species primarily causing pancreatitis, which of course can lead to someone being hypotensive and requiring hospitalization, ICU admission, etc., which you can see below. And this is another, again, very common thing that we might see in these areas that people may not even pay much attention to, resulting in these stings to go left unnoticed, or to result in someone becoming a little bit more ill and not recognizing it earlier as a result.
Thanks, Dr. Frank, for coming over those awesome slides. I'm Dr. Jonathan Meadows. I'm a medical toxicology fellow at the University of Arizona in Tucson. We're going to get into herbal and traditional medicines. So, according to the WHO, 80% of the international population uses traditional healers. Intentional and unintentional poisonings are common. In a 2-year retrospective study of acutely poisoned patients in South Africa, these traditional medicines were the second most common cause of admission and had the highest mortality rate when compared to other agents. For when looking at a 10-year retrospective case review in Zimbabwe, these medicines were the most common cause for admission and also, again, had the highest mortality rate. Ingredients are variable among cultures and regions. In South Africa, there were 41 autopsies that were performed on patients who had passed that had related deaths to traditional medicines, and 44% of those cases were related to cardiac glycosides, which is a significant amount. And then also within these medicines, there can also be contamination and other adulterants that are added, such as heavy metals, corticosteroids, and pharmaceuticals. Coming into the U.S., the FDA tracks the variety of herbs and supplements, and there is a list of announcements where there are heavy metals that are found in these products and then are notified to the public. So pharmaceuticals are another source of toxicological importance in terms of affecting patients from a global aspect of it. They are relatively rare in lower income countries, but as we get into more urban settings, those then of course change. And we see the rate of poisonings related to pharmaceuticals go up. We also have xenobiotics that treat infectious disease, such as dapsone and chloroquine and isoniazid, that are culprits in these cases. And even related to trauma and to robbery, there can be benzodiazepines that can play a role in those type of events. So there's also the issue with poor quality of the manufacturing of these medications, and nearly a third of all of these medications, especially in Southeast Asia and in Sub-Saharan Africa, they are known to either be substandard or counterfeit, based on the on studying these agents in these areas. It's often harmful adulterants. For example, there were 50,000 infants that were hospitalized in China, where formula was contaminated with melamine, and then diethyl glycol poisonings are common throughout the world still, being placed in cough syrups and acetaminophen syrups, toothpaste, and other products. I get updates about infectious disease things sent to my phone, and I get updates about poisonings across the globe. And seeing DEG is one that pops up. Household products are another source of poisoning, like internationally. They include fuels, cleansing products, rat poisons, insecticides, body care products, and cosmetics. These are internationally recognized as childhood products that can cause poisonings. Of note, when we look at Sub-Saharan Africa, we see that 80% of all pediatric poison admissions are due to household chemicals. The most common one for pediatric admission in low-income countries includes kerosene, because it's often sold and stored in used beverage bottles, and that can be mistaken for harmless products or drinks. Often these products are used in the setting of intentional self-harm as well. So plants is a broad topic, and they include many of them that can cause harm intentionally or unintentionally, have been used for like millennia. A couple of examples, just for the brevity of time, include yellow oleander, which is here in Tucson, and then we have the sea mango, which is also known as the suicide tree. These two plants have been known to be a cause of mortality in Sri Lanka and in India. Another one is oduvan, which is a glycoside leading to low potassium and ultimately to dysrhythmias. It's also a agent used in self-harm in India as well.
Thank you, Dr. Meadows, for going over those slides. I'm Karan again, so I'll talk about environmental exposures and occupational exposures when it comes to toxicology. So, like we've discussed before, you once again see the disproportionate effects on low-income countries. One example of environmental exposures is indoor pollution from the combustion of solid fuels. 50% of the world still uses fuels like coal, dung, wood, and crop residues, which has a lot of environmental exposure, a lot of smoke output. And there are 2 million deaths and 41 million disability-adjusted life years in 2004 were reported linked to the combustion of such fuels. Additionally, inorganic arsenic in water and food seems to be a significant problem. In 2001, in a Bangladeshi community, there was about 9,100 deaths and 125,000 disability-adjusted life years that were linked to chronic consumption of arsenic-contaminated groundwater. Additionally, 20% of the deaths in that population were linked to arsenic exposure greater than 10 micrograms per liter in the water. So these exposures are significant, and they're something that a lot of people don't know about, especially when they're living their daily lives. They're doing things like, combusting these fuels for heat, for cooking. They're drinking the water that they have access to, and it's these silent killers in these populations. So another topic in this category is modern environmental health hazards. One example is air pollution from automobiles and factories. Then you have things like soil and water contamination by plastics, heavy metals, and pesticides. You also see industrial chemicals and wastes, radiation hazards, and then, the big one, climate change. So when we're talking about environmental exposures, we look at industrial factories and how when they sometimes go wrong, they seem to affect densely populated communities. These factories are often placed in urban areas or other populated communities, and sometimes the communities are populated because the factories are providing the jobs to the community. So you see the town is kind of centralized around this factory or this employer. This was the case in 1984 when we had the Bhopal disaster. So the Union Carbide factory ended up releasing isocyanate gas, which killed around 3,700 people and injured 558,000 more. So again, Bhopal was a very densely populated community around this Union Carbide factory, and so when something went wrong, you had a lot of people affected by it. There are also new industries that aren't regulated yet, such as electronic waste or e-waste, and a lot of times they reclaim metal from electronics by burning. Again, it's a new industry. It's not really regulated yet, and burning causes a lot of environmental and occupational hazards. And when you look at it, economic hardship and the lack of employment opportunities makes avoiding these jobs extremely difficult, especially when you look at communities in international areas like Bhopal was in 1984. There might be one or a few employers, and despite there being maybe known risks, maybe undisclosed risks, there's not really a lot of a choice. So now we'll talk about how we can reduce the global impact of poisoning. And when we look at this topic, it becomes clear that a multifaceted approach is needed. We need increased research in regulatory sciences, increased prioritization and funding for research, coordination of agencies in multiple sectors. We need policy to improve product and environmental safety. We need improvement in data collecting, and we also need timely access to medical care. And so I'll talk about the policy and the access to medical care a little bit more. So when it comes to policy, it is clear when you start to dig into this that there are many reasonable policy changes. There are already a lot of these type of policy changes in higher income countries. Things like routine childhood lead testing, vehicle emissions regulations, carbon monoxide detection, child-proof containers, and pharmaceutical and food safety regulations. These are all things that we're already used to in our daily lives living in high-income and first-world countries. But these are not things that are in place in a lot of developing countries in the international world. So when you look at one thing that can be done at the policy level, it is reduction of access through country-wide legislature. For example, one example of this working was when Sri Lanka banned all WHO high-risk OP insecticides, and things like organic chlorine and endosulfan were banned. And we talked about earlier how a lot of these products were actually used in self-harm. So when this happened, looking at the 10 years between 1995 and 2005, Sri Lanka saw a decrease in the national suicide rate by 50%. That's a huge, huge number. Additionally, some WHO member states have yet to ratify various international treaties and agreements, and the ratification of such policies can really improve international effectiveness. So not ratifying these has significant detriment. And additionally, regulatory systems are needed to allow organizations to offer safe products to citizens in other countries. So another category under this topic is the timely access to healthcare. There is the lack of human resources, which is a significant problem. For example, there's 60 times more physicians in North America than sub-Saharan Africa. And one estimate suggests we need 4.3 million more healthcare workers globally to combat the international problem of poisonings. Additionally, training in clinical toxicology is needed for existing healthcare workers. Goldfranks once again suggests that input from experts in medical toxicology improves outcome, reduces hospital stays, and healthcare costs associated with acute poisonings. However, less than half of all WHO member states even have poison control centers, and existing ones may be underfunded and may be understaffed. Additionally, under the umbrella of timely access to healthcare, in terms of antidotes, we either don't have antidotes or knowledge of how to use these antidotes is often limited. For example, the greatest challenge to snake bites globally is antivenom availability, as current antivenoms are either expensive, they're sometimes unsafe, or they're even hard to manage. And then getting to the end here, we can also look at disasters and current events when talking about a lot of environmental exposures. For example, in the ancient world, we have Mount Vesuvius near Pompeii, and we kind of know, what that ended up doing to the town of Pompeii and its citizens. In warfare, we have World War I, which produced chlorine, phosgene, and mustard, which had detrimental effects on those around these chemicals. The Holocaust had its own issues in terms of their gas chambers, Zyklon B. In 2002, Russian military used these mysterious fentanyl gases to incapacitate Chechen rebels. There's also countless examples of radiation exposure, from Chernobyl in 1986 to Goiânia in Brazil in 1987. That one had exposures of cesium-137. There was more recently the Fukushima disaster, where the nuclear plant had its exposures due to the 9.0 magnitude earthquake and the tsunami. And then again, with the Ukraine and Russian conflict, Chernobyl becomes another issue of talking about. And this is obviously not an all-inclusive list, but there's many examples of environmental exposures causing a lot of poisonings due to, whatever factors.
Thanks, Karan, for going over those awesome topics and slides. We've got our final slide here that's going to covering just some closing remarks. We went over a survey of the life-threatening toxicological conditions through a global health lens. If you'd like to do a global health EM elective, please reach out to your appropriate faculty, and then consider starting planning now. You can certainly reach out for them for current opportunities and explore future ones. For looking up for standards for global health rotations, you can start by going to the Consortium of Universities for Global Health, or CUGH. The important point is to think globally and act locally. Just in the past month, I went down to a global I did a global health experience by going to a local free clinic in Mexico, just across the border. There are journals that have articles that give some additional standards and information. There's EMRA that has some other ideas and standards as well. And then to keep in mind, there's a multitude of opportunities, such as the WHO having opportunities to study tox conditions across the globe, as we can see this poisonous snake in Australia.
So thanks, John. So that is our lecture on medical toxicology being observed through an international perspective. So if you would like to know more about our works cited and the resources that we used, or how to send us questions, or even contacting us for any further information, please scan the attached QR code. But otherwise, thank you so much for listening. I hope you guys learned something, and until next time.